This conference will now be recorded. Go ahead.
Okay, welcome everyone. This is Terry Hill with TASC, and I'm joined here by Nicole Clement and Tracy Morton, and then Caleb is also with us as a part of this, and we'll actually be saying a few words later on. The topic for today on our TASC 90 call is on financial performance, specifically looking in the transition from our current payment system, which probably current isn't even accurate at this particular point. We are so rapidly moving into this new kind of value-based reimbursement system, the population health system, et cetera. And so that's going to be the basic topic of conversation today. We have some examples in terms of some flex programs that have been doing some really impressive works in this area. We're going to hear from Dr. Clint McKinney, who's representing Rural Health Value, and particularly their new forecasting tool. Something pretty specific here, just a good tool and resource that our state flex programs can use. Dr. McKinney is going to talk about a little bit more and also answer any questions you folks might have. We're going to first of all hear from the Federal Office of Rural Health Policy. Sarah Young and Wakina Scott are actually Tracy's going to lead things off, so let me just amend that, and then we'll hear from the Federal Office. We'll have then a real discussion of these financial strategies to assist critical access hospitals in their transition to value and population health. Karen Madden from the New York Flex program is here, and she'll talk about all that's going on in New York. We asked Lance Keilers, who's the past president of the National Rural Health Association, former hospital administrator, and participant in our recent Financial Leadership Summit meeting, to come and talk a little bit about his perspective. And then I think Caleb Murphy is going to be presenting some comments on an experience that he had a few months ago working directly with rural hospitals. We'll conclude the session with a flex monitoring team update with Sharita Thomas from the University of North Carolina, which you probably know is kind of the designated go-to resource from a research standpoint on critical access hospital financial performance. Again, we would welcome any comments that you folks may have, or any suggestions, et cetera. So do feel free to jump in. You know, whenever you have a question or want to make a comment, or you can also put your comment or question into the chat box. We'll try to be diligent about looking at that as well. So with that kind of as the agenda, I'm going to turn things over to Tracy, who will give us an update on TASC. Tracy?
Thanks, Terry. So one quick thing to note, and that's kind of our big event for the year, the 2016 Flex Program Reverse Site Visit is coming up. It's going to be July 20th and 21st in Rockville, Maryland, hosted at the Hilton, Washington, D.C., Rockville, which is right on Rockville Pike and really close to the Federal Office of Rural Health Policy Office. You should have received an email earlier today noting that registration for the event is now open. The theme for this year's conference is communicating value and opportunities, and we'll talk about communicating value and opportunities not just within the National Flex Program, but also within the context of the state Flex programs and the critical access hospitals and communities, and also value and opportunities that are being presented with this transition into the new healthcare model, and we'll definitely be talking about that today on the call. So registration, as I said, is open. There is no cost for registration, but there is a cost then that each Flex program would incur for lodging and transportation to and from the reverse site visit. When you do registration, you can go to the TASC website, which is ruralcenter.org/TASC, and on the green menu bar on the right side of the screen, you will see 2016 Flex Program Reverse Site Visit, a link there. Click on that and it'll take you to a button to click for registration. You need to register for the event, but also you need to separately book your transportation and lodging. There's information on the website then about lodging at the Hilton Washington, D.C. Rockville. The room block does end on Tuesday, June 28th, so you must make lodging reservations before Tuesday, June 28th to be included into the room block that's set at the particular rate that it is for the event. If you have any questions about registration, please be sure to reach out to TASC. Of note, 2 people per flex program are allowed to attend the reverse site visit. If you have any questions about the number of people, please do reach out to your individual Federal Office of Rural Health Policy project officers. It's at their discretion about additional participants attending. So we look forward to seeing you in a little bit over a month in Rockville. We'll keep content on the website updated, and we'll be updating an agenda on there shortly with more detailed information about the sessions. But we're really looking forward to another great event, and it's just a fantastic opportunity to network, learn things specific to the Flex program, and to talk with your peers. So we're looking forward to seeing you all. Thank you.
Any questions? Okay, then we will move into our Federal Office of Rural Health Policy update. As I mentioned before, Sarah Young and Wakina Scott have joined us, and let me introduce them to you now. Sarah and Wakina.
Hi, Terry.
Hi.
This is Sarah here, and I'm going to go ahead and have Wakina go first, actually, so we don't have to keep her on the line when she reviews your issues and answer your questions. And there, it looks like her slide is up. Go ahead, Wakina. Hey, Wakina, are you muted?
Star 2 to unmute your line.
Okay, now can you hear me? Hello?
Yep, I
We can hear
Go
you. Thanks.
Okay, great. All right. So yes, thank you, Sarah. As Sarah mentioned, I'm Wakina Scott, Policy Coordinator with the Federal Office of Rural Health Policy, and I wanted to just bring to your attention a few policy updates since your last call. First up, the hospital inpatient prospective payment system is now out for public comment. Comments are due June 17th. A couple of things that I wanted to bring to your attention for this particular proposed rule. First, related to the 2 midnight rule, as you may know, CMS is withdrawing from this particular policy, and so in this proposed rule, there is a permanent 0.2% increase following the withdrawal of the 2 midnight policy, and a one-time 0.6% increase to remove its effects from fiscal years 2014 through 2017. And what CMS is projecting is that rural hospitals will end up receiving a larger payment increase of about 0.8% than some of their urban counterparts. For the Medicare uncompensated care payments, again, in this rule, CMS is proposing to distribute roughly $6.6 billion in uncompensated care payments in fiscal year 2017, which is a decrease of about $400 million from last year. And what they're proposing to do is implement a 3-year transition period beginning in fiscal year 2018 that replaces the proxy data, or that data on low-income insured days, with data from the cost report worksheet S10 to determine the amounts and distribution of DSH payments to eligible hospitals. So CMS is projecting that the decrease in DSH payments at rural hospitals based on this proposed change will be substantially larger than the reduction for urban hospitals, about a 4% to 1% deduction, rural versus urban deduction. The other thing I wanted to your attention was this Medicare outpatient observation notice, what they're calling the MOON. And so again, CMS is proposing to require hospitals and CAHs to provide written notification to individuals receiving outpatient observation services for more than 24 hours. And this is coming as a result of the Notice Act, the Notice of Observation, Treatment, and Implication for Care Eligibility Act. And again, requiring hospitals and CAHs to provide this notice to a Medicare beneficiary who's been receiving services, observation services as an outpatient for more than 24 hours. And the notice they're proposing must be provided no later than 36 hours after observation services are initiated. So this particular notice, what they're calling the MOON again, is going to go through the Paperwork Reduction Act process. So there will be an opportunity for CAHs to provide comment as to the burden of completing this notice, of providing this notice to beneficiaries, and so forth. And the last thing I wanted to highlight under the IPPS rule is the Frontier Community Health Integration Project Demonstration, or the FCHIP demonstration. So what this proposed rule is doing is adopting a contingency plan to ensure that the statutorily mandated budget neutrality for the FCHIP demonstration. So they're saying that if during this initial demonstration period, which is this year, calendar years 2016 through 2019, shows increases in Medicare payments that are greater than expected savings, CMS will then make payment reductions to all CAHs nationwide, estimated to be no greater than about 0.03% of the CAH's total Medicare payments in a given year. And they're going to start this reduction over 3 years beginning in 2020. So again, that's only if the analysis of claims and cost reports during this initial demonstration year show increases in payments rather than the expected savings. For the macro rule, or the quality payment program, or the merit-based incentive payment system and alternative payment model rules, it has a number of names for this particular rule, and you've probably heard a lot about it, but I've put it on our update since this particular rule was not out during the last webinar. And as you're aware, on May 9th, CMS published this proposed rule that makes changes to how clinicians will be paid, and so they're moving to evaluating quality of care based on 4 performance categories: cost, quality, use of electronic health records, as well as the clinical practice and improvement activities. And they're also proposing use of advanced alternative payment models that will offer higher financial incentives to clinicians who improve quality by coordinating care across providers and settings. And some of these advanced APMs will include some of the accountable care organization models, as well as the comprehensive primary care models. One thing that also wanted to highlight was that the MIPS adjustment, the merit-based incentive payment system, would apply to eligible professionals who have assigned their billing rights to CAHs. So the method to billing professionals will be subjected to the MIPS program, the policy under the MIPS program as well. And very important for you to provide comment on this particular rule, which again is really changing the game for how clinicians will be paid under Medicare. Comments are due for that rule Monday, June the 27th. And again, the official name of the rule is Merit-Based Incentive Payment System and Alternative Payment Model Incentive under the Physician Fee Schedule. The other thing I wanted to bring to your attention is the changes to the State Operations Manuals for the CAH checklist. So on March 25th, CMS published revisions to the CAH recertification checklist as transmittal number 153, and the checklist is one of the exhibits in the State Operations Manual used for evaluating the compliance of currently certified CAHs with the status and location requirements found at 32 CFR 485-610. So again, this transmittal really just implements changes that were announced in the February 12th memorandum to state survey agencies. It doesn't make any new changes. It just merely adds the changes, the February 12th changes to the manual. For the request for information on the multi-payer budget concept, again, the comment period has come and gone, but again, something that if you haven't heard of or are not aware of, is something that you should be paying attention to. CMS will most likely be providing further information based on the comments that they provided, either moving forward with some type of demonstration program, but we have not heard further from CMS at this point as to what their next steps are. But again, they did put out this request for information to explicitly looking for input from rural providers on a regional multi-payer payment model similar to the Maryland all-payer model, and really was looking for that insight on how it can affect the historical financial protection for critical access hospitals as well as other rural hospitals. If there are continued questions related to that particular concept, CMS does have an email address. It's really simple, regionalbudgetconcept@cms.hhs.gov. If you have any questions or anything like that, feel free to send CMS an email, and I'm pretty sure they'll still be addressing questions even though the comment period has closed for this particular request for information. For the and lastly, I really wanted to highlight the Rural Open Door Forum that you may have heard about, June 14th at 3:30 p.m. CMS put out a save the date for this time. When I last checked today, they have not put out further information as to the call-in information and so forth, or an agenda, an official agenda. But in the save the date, they did highlight the fact that they wanted to discuss the fiscal year 2017 budget, the CMS's budget, that includes a series of Medicare legislative proposals that pretty much will help extend the life of the Medicare Hospital Insurance Trust Fund over a number of years, over 15 years. Among these proposals, however, is the proposal to reduce the CAH reimbursement from 101% reasonable cost to 100% of the reasonable cost, and they project that this will result in a savings of about $1.7 billion over 10 years. So they're saying they're using this Rural Open Door Forum as an opportunity for stakeholders, the public, critical access hospitals to really provide comment about this proposed budget change, and to, it's just an opportunity to give CMS this important feedback on really big change for critical access hospitals. So that's all that I have on my end as far as updates, and I'll just stop there to see if there are any questions.
Any questions for Joaquina? Sarah, did you have anything else to add?
Not to the policy updates. I've got one quick flex program related item to address. And I'll note that Catherine Miller shared the dial-in information for the June 14th call. I believe she got that from one of the CMS regional coordinators in the chat box on the side there. If you haven't noticed Catherine's note yet, thanks for putting that up, Catherine. So I just wanted first to say this is my first TASC Heidi as your new Flex Program Coordinator, and I'm really looking forward to working with everybody in the program. We have a great group of grantees and other stakeholders, as well as the hospitals and communities that are our ultimate clients of the Flex program. So thank you all for having me, and never hesitate to reach out to me as to how I can do better as your Flex Program Coordinator. With that, I wanted to share a couple, or a single issue really, that we are seeing in some of the progress reports and work plans as we're starting working on the NCC reviews. So let's see, I do have control of the slides. The issue I wanted to highlight is that the Flex grant guidance is pretty explicit that grantees must report data in your progress report, and that really is, I think of measures as where you're defining the concept. Number of cause that improve patient safety by improving vaccination rates. But what's the measurement? What's the actual number, the baseline and target for that measure that you previously identified in the grant applications? Just as an example, this is a direct quote from last year's competing continuation guidance. The referenced activities 1.01 through 1.08 and noted that required measures include baseline quality outcomes and targets for quality improvement in the quality areas where grantees are working. There's similar language in the other sections that just happened to be the one I copied. So to help people get a better idea what I mean by baseline data, these are short phrases I quoted directly from some of your current NCC progress reports. For example, one grantee reported that Flex monitoring team data showed 78% of patients seen at 12 CAHs received their influenza vaccination during the 2012-2013 vaccination year. That's an example of getting a baseline from older data. That's great. I realize sometimes you don't have last year's data available yet, given the data lags in quality reporting programs. Here's the second bullet on this slide is an example of a baseline with a target. The grantee reported currently 86% of CAHs are reporting the EDTC measure. Our target by the end of year 2 is to have 100% of CAHs reporting the EDTC measure. Again, these are examples of grantees reporting data in this progress report. A couple of more. Reporting rates of OP27 and IMM2 reporting were in this state were under 50% in April of 2015, but as self-reported by the CAHs, were up to 83 and 76% in April of 2016. You gave me a baseline, you gave me updated data. I realize that is probably coming from CAH self-reports, not from the NHSN data system because of data lags. But again, that's great. That's showing data that to the progress of the grant report. And then finally, I pulled out a couple of examples of things that didn't have baselines. The first bullet on this page, the grantee was talking about a project that required recipient CAHs to provide a baseline and target goal for at least one of the following: a change in accounts receivable, a change in revenue, or a change in denial rates. They reported that these subcontracts had been awarded to participating CAHs but didn't report any baselines for those metrics. Another example is a grantee reporting that our measure for activity 1.03 is % change in EDTC measures for CAHs that participated in training. Well, what did your EDTC rate start at before you began these training programs? So that's just a couple of quick examples. I realize I rattled through them pretty fast, that we're going to be sending some of your work plans back to ask for data. There were also a couple of really great examples that grantees provided data tables with your work plan, which is not the only way to do it, but it is a good way to consolidate your data reporting, and something that I'm going to ask for feedback on how's a good way to do that in the future. So I just want to give everyone a heads up to expect some conversations from your project officer about amendments to the progress report, and a lot of it is going to be about identifying baseline measures or baseline measurements for your identified measures in your work plan this year. And I realize this is a process, and we don't always have data as timely as we'd like, but it's something we're going to keep working on. And if you have any questions, there's my contact information. You can also talk to your project officer. And with that, I'll say any other questions on the line? Stephanie, I see in the chat you wrote that I struggled to find data for some of the new measures because Telegen reports are not available yet. That is very true. And I believe if there wasn't a timeline about when we would have Telegen reports with the new measures in the last InvQuip monthly, it will be coming in the next one probably. I don't know the exact dates off the top of my head, but it's underway. Yvonne may be answering that as I'm babbling. Any questions on the phone? *2 to unmute your line. And yes, Yvonne reminds us that some of those outpatient and similar measures are also in the FMT quality reporting data reports from this year and past years. The FMT reports are pulling a wide array of measures from Hospital Compare in addition to the InvQuip. Any other questions on the phone line? I don't think so. Thank you for answering questions in the chat, Yvonne. I'll hand it back to you, Terry.
Thank you very much, Sarah. And you know, it's nice to have someone like yourself in your new role, kind of with the background with rural hospitals, et cetera. So I know that one of the things that you've been doing and hopefully continue to do is to track the closure of rural hospitals. And at last count that at least that I've seen, we've had 74 rural hospitals close across the country since 2010. And of course, this kind of reflects the new financial challenges that these hospitals are facing. And it kind of brings us back, those of you that are old enough to remember, to the kind of the status of our rural hospitals back in the 80s and 90s. We had several hundred hospitals close across the country, and then of course the critical access hospital funding kind of provided that lifeline in the Medicare Flex program, provided support mechanisms, etc. But now we're facing another, if not crisis, then certainly very serious situation where our rural hospitals basically not only are closing in greater number, but we see that many of them are financially challenged, and again, I refer you to the reports coming out of the University of North Carolina, who will be speaking later on this as well. So what we want to talk about today is going into a little greater depth about kind of this transition, the challenges that we're facing. We have some folks that are totally on top of these changes and understand the financial ramifications and issues, and others that might just be beginning and are still trying to sort through what critical access hospital financing is. For many of us, it's taken years to kind of fully understand critical access hospital funding, and just when many of us have got it down, we now have all these new concepts and all these new programs being introduced. It is going to be extremely important that our rural hospitals understand the opportunities, the challenges, et cetera, as we're moving forward here in this transition into new payment systems. And I think it's also going to be very important that our state flex programs kind of understand these changes, can help design and work plans and strategies, et cetera, that can provide at least as much support as possible, and just basically make a smooth a transition as we can possibly do here. So we do something here at TASC that we've been doing historically almost since the time of the Medicare Flex program actually being passed, and that is holding financial summit meetings, and or just summit meetings in general. We've done summit meetings on quality. We've looked at population health, on networks, et cetera. And in fact, the regulations and a lot of the Medicare Flex program was actually put together by a group of folks that met, I believe it was in Chicago in the late 90s, to advise the Federal Office of Rural Health Policy in terms of how they could really maximize the effectiveness of the Flex program. So there were folks from the State Office of Rural Health, I think the American Hospital Association was there, et cetera. And I think the collective input of that group really had an impact on what I think has been a really successful program over the years. We've done that here at TASC and at the center on the topic of finance now several times. As you may recall, 3 or 4 years ago, probably closer to 3, we convened a group of what we thought to be the best financial consultants and researchers and state office people in the country to come up with a list of financial indicators that they deemed to be the most important. And I'd refer you to the document that's certainly on our website on the financial summit meeting outcomes, et cetera. So that's been really helpful from what I've heard to the consultants, to the Flex programs, et cetera. But we also wanted to go into greater depth on some of this as well and produce another document that we could share with Flex programs and hopefully with the hospitals as well on this very specific topic of transition to value in population health. So a couple of months ago now, we convened a group of folks in Minneapolis. Both Greg Rosenbaum and Marcus Pigman were a part of that group, but there were also consultants and CFOs and hospital administrators and researchers, et cetera, that are part of that group. And at our reverse site visit, we're going to basically present the first of the outcomes of that meeting. So I'm not going to go into any great detail on it, but I do want to let you know that it is coming, that we think it's going to be an important document. And I just want, kind of want to give you a heads up that it'll be there and that it should be very useful from a resource standpoint. Again, these documents are intended to supplement the good work of our research centers. They're not intended to be, the same type of research, but rather kind of the collective wisdom of a group of folks. So I'm going to set up the conversation today a little bit in terms of, again, what everybody agreed was the direction that we were moving. And that is that there's just no doubt anymore that we're leaving this fee-for-service, cost-based, reimbursed, volume healthcare system, and that this is actually a picture of where I grew up, very close to where I grew up in the Yukon Territory of Alaska. And so we're going to use this visual, and I'm sure you've all heard of it before, crossing from one side of the financial payment system to the other side. That's the Yukon River, by the way. And the reason we're leaving it, and this is very important to understand for those of you that, I'd say most of you know this, but in essence, our current cost in particular is no longer sustainable in the world economy and the world market. That means that both Democrats and Republicans pretty strongly favor this from what we know and we have heard on the inside. No matter who gets elected president, the support for this transition to value and population health payments will continue. They're already underway. Many of these concepts are Republican as well as Democrat in terms of where we're going. I'm not going to go into the kind of the ugly statistics that show this highest cost in the world. I think we rank 37th in terms of quality. Huge chronic illness population, particularly diabetes, and before we passed the Affordable Care Act, we had 50 million plus who had no health insurance whatsoever. Unfortunately, and I can say this on behalf of all of the rural hospitals in America, as well as probably our staff, and I know I speak for many of you as well, not all the states, a good many of them, have not passed this Medicaid expansion, and our hospitals are really suffering because of that. Now, it's moving into this whole new dimension, and this triple aim that to some may seem like pie in the sky is actually playing out in the real world. We're seeing better care, an improvement, for example, on the part of the accountable care organizations, at what it was about 19% improvement in quality. Smarter spending, costs are being, and waste is being taken out of the system. Again, no question about the fact that we are saving money, both in Medicare and in Medicaid, and the spending saving is obviously there as well. And we haven't necessarily produced healthier people, so I'd like to be able to report on that. That's going to come down the road, but there's an investment now into wellness and prevention programs, and I'm feeling very confident that we're going to achieve that those goals of healthier people, as well as the savings and in the improvement in quality. Now, the reason I say that is partially due to this, and these are the slides actually come from the federal government itself and from Medicare in terms of these are the goals. Again, if you look at 2016, you could say, well, how are we doing then? The projection was that alternative payment models, which I'm going to talk about in just a moment, were going to be at 30% by the end of 2016. What I can tell you is that's been exceeded already. So already we have over 30% of payment, Medicare payment now going into these alternative models, and the projection is that by 2018 it's going to be over 50%. I would, just given the speed of the transition, I would suspect that that's going to be well over 50%, and we're going to be well over 30% by the end of this year, because we have a variety of different programs that are being unveiled yet this summer, some of them starting on July 1st, as a matter of fact. So the lighter blue in the figure is the payment that is linked to quality as well. So it is pay for performance in that regard, and the goal in 2016 is 85%. I believe they've already exceeded that, and we're moving to 90% plus in 2018. That does not mean that cost-based reimbursement is ended or there's a direct threat to critical access hospitals, but as I indicated before, already we see critical access hospitals closing across the country, and we think it's very important that if not getting into these alternative payment models, that we at least start to understand them and start to prepare for that transition. So one of my last slides here is just these models, and again, some of them are fairly complicated, but they're going to have a profound impact, if not on our hospitals, then certainly on our primary care practices, which, as you know, are kind of the essential pieces with our hospitals. So the first one of the accountable care organizations, we've seen rapid growth in this area, and until very recently, it hasn't been rural hospitals or rural clinics that have been a part of these, unless they've been a part of bigger healthcare systems. We just had several conversations last week with hospitals that really want to do ACOs and are a part of urban-based ACOs, but they simply have been left out. Even though they're considered a part of the ACO, they're not given any support to transition, to do care coordination, to develop the capacity. So just being in a urban-based ACO doesn't necessarily mean you're going to be prepared or be successful in them. Some bigger healthcare systems have done a terrific job of involving their rural hospitals, so it really varies kind of given where you're from. We know that in Utah, for example, the big healthcare systems have really led the way and have provided a lot of support for rural hospitals. As of January 1st, there were 41 new accountable care organizations that were rurally based as part of the AIM program that specifically designated resources for rural hospitals and clinics. I think up to about 170, 180 hospitals and clinics are now part of the National Rural ACO, and I could just say from personal experience being on their board that there just seems to be a massive movement in this regard. We have ACOs representing the hospitals in Illinois, for example, Washington, Colorado, New York, pretty much across the country. So we're seeing rapid movement here. The pioneer ACOs are the old ones. There were really no rural-based ones to my knowledge, and we're coming into various next-generation ACOs. Now, the thing about next-generation ACOs is they're going to have risk involved. Right now, the accountable care organizations that our rural hospitals are participating in, basically don't have any downside risk. In other words, they can't lose money on their ACO participation, but they're eligible to make money. They get to shared savings. They get a proportion of those, usually half. So there's front side on it as well. What we're finding just from the early rural ACOs, just quick feedback here, is they're not hitting the quality guidelines because they're not doing wellness visits, and there are a whole new set of quality guidelines or quality measurements over and above what we're already doing for Hospital Compare and MB-QIP. But basically they're prevention and wellness oriented, and so it becomes really important that our clinics and hospitals do annual wellness visits. We also find that the quality is hampered by a lack of coding or undercoding as well. So in other words, hospitals and clinics are not coding as well as they could, and consequently when CMS looks at the data, it looks like our rural patients are actually a lot healthier than our urban patients in that regard. So something to keep in mind. The other thing I'd point out on that is that the Michigan State Office of Rural Health has taken responsibilities of helping to manage two accountable care organizations in Michigan. So talk to John and Crystal if you want more information about that. The other pieces here, the bundled payment. The one that's of particular interest right now is the joint replacement here in the middle, comprehensive care for joint replacement. So that simply means that CMS is going to pay a lump sum for comprehensive care for joint replacement. That means the rehab providers, the hospital providers, the clinic providers are going to have to share the fee. And that's something to be watching for. And one of the real issues that's coming up here is swing beds, and during rehab, is swing bed a better investment than a local nursing home, for example? So I just want to bring it up. I think we can argue that the quality of care is better, but I will tell you that it's somewhat of a controversial item. Advanced primary care really is coming up here as well as something important. Watch for the CPC or kind of the primary care provider plus system that's coming out in early July, because it really has a significant amount of financial benefit. Possibly, we're going to have to see how this plays out, but there seems to be some real reimbursement advantages for hospitals and clinics that participate in it as well. So do call us. I believe Joaquina's got somewhat of a background in this, and certainly we can help if you want more information about this as well. So the challenge here is crossing the Shaky bridge. As our hospitals are being paid cost-based or fee-for-service, our rural hospitals, and moving into this other dimension, we're very concerned that some of them may fall off the bridge and may close. We believe that, in essence, there is a future there, that there is a place for rural hospitals in the new payment systems. Certainly, local care and community care is going to be of huge value, and that's kind of what I wanted to say today, kind of setting up the conversation we're going to be hearing. Now, hopefully, Dr. Clint McKinney has joined us, and Clint is going to be talking about a new tool that Rural Health Value has put together in terms of forecasting.
Hi, Terry, it's Clint. Can you guys hear me okay?
Clint. We can. Yeah, thank you, Clint.
Good deal. Well, look, I'll be quick because I want to hear from Karen and the other folks. So but we will be quick here. And you guys just have to help me. Let's see if I've got control here. I do. Son of a gun. Wonderful. So Terry was just describing these alternative payment models, and you all may remember Secretary Burwell announced these about 18 months or so ago. And I think all of us in healthcare policy were aware that CMS was going to do something like this. We were just surprised that she did it so fast, that expectation, as Terry was describing, of things to move into alternative payment models by 2018. So here's just a little bit different graphic, and for those as a review, when we talk about alternative payment models, we're talking about ACOs or shared savings programs, patient-centered medical homes, or which is now being called advanced primary care, and bundled payments. And this is what she was describing should happen, and just as Terry said, in February we met that 2016 goal of 30%. But then, I mean, most of us are still in fee-for-service. So you might ask, so what happens to our fee-for-service payments, and how's that changing? And here's what our goals were, that by the end of 2018, 90% of even the fee-for-service payments, which includes cost-based reimbursement, would be linked in some way to value. And Terry used the word pay for performance, and I think that's a good one to talk about. We have kind of straight fee-for-service, we have capitation, we have shared savings, and we have pay for performance, which is kind of what she's talking about in this second bullet. But this aggressive timeline, as I was describing, really, I think, may challenge us. It's favoring those organizations that already know how to manage financial risk. They already know how to take care of the health of populations. When I was in private practice in Iowa, I think I gave pretty good care to the diabetics that were sitting in front of me in the office. But then they were gone for 18 months, and I was absolutely clueless. That's not population health. And it takes an entirely different set of kind of infrastructure and policies and resources to be able to take care of populations. And some organizations have that experience, and many of us do not. The other thing that this aggressive timeline is going to favor is those organizations that have deep reserves for the transition. We kind of need that money up front to weather this storm of change. And again, for those of us in rural, that may be more challenging. Yet, as Terry was describing with NRACO, now called Caravan Health, we are learning how to compete in this new world, and many are already doing so. And let me give you a kind of a quick example of that. So this is a map that we put together at Rupri showing Medicare, only Medicare ACO presence by counties, and the kind of the greenish blue are rural counties. And you see what that was in 2013. Now take a look at this in 2015. Look at the difference, how much this has expanded. It's a good graphic representation of how fast this ACO concept or shared savings concept is spreading across the country. You know, in kind of just numbers, in my slides, I tend to use these numbers like 700 plus and 400 plus because it's changing so fast. So right now, there's well over 700 public and private ACOs in the country serving over 20 million patients, over 400 Medicare ACOs, and you saw that map that I showed you just a moment ago of how geographically broad this is. 49 states in the District of Columbia are they operating in. So this is a force to be reckoned with. It is moving. You know, interestingly, I think it was in 2012. So this is 18 months or so after the ACA was passed. And 2012 was just when ACOs were starting. And I had a chance to talk with Elliot Fisher. Elliot Fisher is the guy who invented the name, he and Mark McClellan, ACO. And he said, yeah, Clint, I think this ACO concept's really going to take off. And I said, I don't know. You know, we're a little bit more cautious in rural. You know, I don't think it will. We'll just have to wait and see. Boy, was I wrong. It really has taken off. Unless you think that's only Medicare, not true. In 2014, 40% of commercial payments, in-network commercial payments, healthcare payments, were linked to value. Compare that to 11% in 2013. I don't have the 2015 numbers yet, but I bet you $10 it's even greater yet. And an organization that was kind of a consortium of both providers and consumers and businesses and payers were committing to 75% of commercial health insurance payments linked value by the year 2020. So as you can see, it's not just Medicare, it's all moving kind of in this way. So as I kind of wrote here in this last bullet, value-based payment has legs. Whenever I talk about this, there's usually some old guy with gray hair, that actually probably looks like me now, but some old guy with gray hair, usually a doctor, says, oh, geez, I've been through the managed care of the 1990s. This will never happen to us. Well, I don't know. I don't think that's true. I think it will. And I don't think it's necessarily going to be ACOs. But think about ACOs as pointing the way to replace fee-for-service. Think about it that way. It doesn't mean we're going to all be operating under ACOs 5 years from now, but it's pointing the way to replace fee-for-service. In fact, we're talking now about accountable care communities. You know, and for those of us in rural, that should really excite us. I mean, that's what we want to be. We want to care for our communities. Now, some of you may be pretty sharp mathematicians, and you saw that 90% of fee-for-service payments linked to value or pay for performance, as Terry used, which I certainly agree with. But then you say, well, what about the other 10%? You know, actually, isn't rural payment, 10% or less of the total payments in the country? Can't we kind of remain under the radar of this darn value-based payment stuff that Terry and Clint and others are talking about? And wouldn't that be a good thing if we kind of stayed under the radar of this stuff, to stay out of the way? Well, I want to try to convince you that I don't think that's a good idea. If we continue to stay under the radar, and I think a lot of people would argue that we're too much under the radar right now when CMS is designing its demonstration projects. What I worry about is if that were to continue to happen, the new grants for innovation are going to go to big systems. They're going to go to the places that already have the data analysis capacity, that are going to already know how to do quality improvement, who already are kind of operating efficiently and can show big numbers to kind of show that demonstrations are expandable elsewhere. So all of a sudden, if we kind of say we don't really want to be a part of this, the money that's flowing out of Washington, D.C. and our state capitals may not be flowing to rural, it may be flowing to systems that are already starting to do this. And physicians aren't stupid. They want to align themselves with winners. And we already are seeing situations where physicians jump ship. And they jump ship to successful ACOs that may be urban-based. And yes, they can take their patients with them, and they can change hospital referrals. When you see organizations like Lowe's and Walmart and even local companies shipping their patients to distant centers of excellence for higher value care, and they're shipping their families along with them, by the way, and they're paying for hotels, by the way, and they're still getting a better deal, if that can happen to rural as well, too, and that can happen with our physicians. They can change hospital referrals. I talked to a rural-based physician-owned ACO, and, I asked him, why aren't you partnering with your rural hospitals? And guess what the answer was? The answer was, we want to be able to select the highest value hospital care for our patients. Well, we in rural need to be playing in this game to demonstrate that we are high-value organizations. Because if we don't, I think we'll develop a two-tiered health system, urban and rural, value-based and volume-based, and, separate is rarely equitable. So I'd like to argue that we need to be kind of playing in this new value-based space. Now, let's just say, however, that you are one of those gray-headed guys in the back row, kind of muttering under his breath when Terry Hill is talking or Clint is talking, and you say, I think I can make it. I can make it on cost-based reimbursement and fee-for-service. Well, first, I would remind you that cost-based reimbursement ain't what it used to be. When we have expanding Medicare Advantage in this country that does not require contracts that are cost-based with critical access hospitals, and Medicaid managed care, if I remember my numbers right, I think I'm right about this, 29 states right now are employing managed care organizations to manage their Medicaid. Medicaid managed care doesn't have to offer cost-based reimbursement. In fact, the state of Oregon doesn't. I worked with them quite a bit when they transferred 15 out of the 32 rural hospitals off of cost-based reimbursement from Medicaid to PPS. So we're seeing this kind of loss of cost-based reimbursement guarantee. But let's envision a future 5 or 6 years down the road when we have a fee-for-service, cost-based reimbursement future, and let's throw in some reasonable assumptions. And you all can argue with these, that's okay, but I think these are probably reasonable. I think it's reasonable that we in rural hospitals are going to have increasing competition. We're going to have increasing competition from the CAH down the road. And of course, we're going to have competition from urban systems like we've always had. And just as Terry was describing the three-part aim, or the triple aim for IHI, three-part aim for Medicare now, it's going to be based, competition is going to be based on quality and cost and service. You know, I can hardly imagine our labor costs and supplies, and get this, EHR technology costs are going to be going down. So those costs are going up. And if anybody on the call thinks that we're going to get wild increases in our payments from either the feds or from commercial markets, please raise their hands. You guys are on drugs. So that's not going to happen. So we're not going to get wild increases in our payments. We will see increasing physician alignment with successful healthcare organizations. And if that alignment is anywhere else but with us, we will likely see decreasing physician-driven CAH revenue in inpatient and ancillaries. So I think those are probably reasonable assumptions. So what we did with Rural Health Value, and thank you to Akina and Sarah Young, who are on the call right now from FRHP, for supporting the Rural Health Value project that takes place at University of Iowa, where I'm located, and then also with Stratus Health located in Minnesota. What we did, we put together an Excel-based pro forma to help that rural hospital, rural CH CEO, CFO, kind of try to make a decision about where does their hospital, what will their hospital look like financially in 5 or 6 years if CBR and fee-for-service are sole sources of income. And now the cool thing about this Excel-based sheet is you put in your own data from your financial statements, from your PSNR, from your cost reports, and then you do some forecasting as well too. But it's not hard. You know, you want to know something dangerous, ask a doctor to talk about finance stuff. And Eric Schell actually helped us. Well, he did most work, put it together, and then, but at least I could even follow along with what he was saying, and that's a big thing to happen. And we figured this will probably take an hour and a half to 2 hours to do. Pretty cheap time of investment to help forecast kind of what your hospital is going to look like 5 or 6 years from now, if nothing changes other than your assumption. And this is what you get back. This is what you get back. This is all free. And here's, you can see the website that you go to for it. It's a fee-for-service, cost-based reimbursement pro forma, Excel-based. It's all free. And go to www.ruralhealthvalue.org, and you can see there how to get to those links. And if you get confused or we didn't set it up right, just email me, and I'll get it to you. And what you'll get is kind of these charts that kind of show you how things look going into the future, 5 or 6 years into the future. Now, we do predict that many CAHs can survive for now under fee-for-service and cost-based reimbursement. But Terry did allude to those that have closed recently, many for financial reasons, many because the economics of where they are just doesn't work. But some will fail and close. So what we hope is that if you run this pro forma and find that, you know, our future under this system isn't quite as rosy as we had hoped it would be, then we're more proactive about reaching out for some of these new opportunities. So to end up, I'm suggesting that as you look to the future, you don't do it in 2 different ways. You don't do it with navel gazing. You don't do it with your head in the sand. That won't get you anywhere crossing the Shaky Bridge. And you also don't do it with blind innovation. Blind innovators will burn through their reserves right away, and a smart board will fire them promptly. So we don't want either one of those. We want smart, sophisticated modeling to drive our financial strategy moving forward. First, When we're sitting in fee-for-service and cost-based reimbursement, we do that really, really well. We don't leave money on the table. And then going forward, we make informed value-based care investments. With the ACOs, the government, every time you turn around, the government's trying to make this program a little bit more palatable, even for us in rural. If you're not already affiliating with your primary care providers, do so. Do so. In a capitated world that flows through a primary care provider, a typical family physician with 2,000 patients in our panel will control about $18 million per year of payments. Do you want to play in that field? Yes, you do. Concentrate on data access and analytics. Concentrate on thinking about a value-based referral network and your place in it, and also begin the process of care coordination. We can talk about the way forward, lots more. That's not the purpose of this call. Instead, it's about to introduce you to this pro forma that we have. Take a look at it. If you have any questions about it, you can email Eric or me, and we'd be happy to answer them. Back to you, Terry. Thanks very much.
Thank you so much, Clint. It is so important, particularly that our physicians understand this transition to value. What we're finding, I think, is that the hospital administrators, the hospital leaders are starting to get informed and know what's happening. In many cases, our medical staffs still need a lot of education and support moving forward. Okay, terrific. We're going to move then to Karen Madden, who's with the New York Flex program, and she's going to talk specifically about the state of New York. So, Karen, welcome.
Thanks, Terry. And thanks to all the folks at TASC for giving us this opportunity to briefly discuss what we're doing in terms of finance for our program. So just by way of background, for all of you that aren't familiar with New York State, it is more rural than a lot of people think, and we have 2.4 million people living in rural communities, and that's out of a total of 19.3 million in the state. So we've got a lot of rural places, but in terms of total population in our state, the rural is just a little bit. We have 224 acute care hospitals. 37 of those are rural or non-metro, and 16 are still community hospitals, and 18 are critical access. For the major focus of our Flex program is our New York State Critical Access Hospital Performance Improvement Network. And we have two work groups in that network. One focuses on finance and operations, and one focuses on quality. And I think that's probably very similar to what a lot of states do. We contract with Stroudwater Associates for their expertise with that network. And New York is currently undergoing major changes in our health system, and it seems like they're happening very, very quickly, like in many other places. And we're doing that under what we're calling the State Health Innovation Plan, which includes a state innovation model grant from CMMI to develop advanced primary care throughout the state, and we are doing Medicaid redesign. Both of those initiatives are focusing on value through lower costs and higher quality by emphasizing integration and care management while stabilizing safety net providers. And we do consider critical access hospitals to be safety net providers, which has turned out to be very helpful for those hospitals. We are a Medicaid expansion state, and we developed our own exchange. So we haven't had any rural hospital closures in New York, and I think that may be part of the reason for that. On our finance and operations group, we are focused on three major projects, and one is financial indicator tracking and benchmarking, and Terry discussed how the metrics that we collect and analyze every quarter came to be years ago, and I think it's, again, probably very similar to what a lot of states are collecting. We have a learning action network that has 3 task forces focused on 340B and swing beds, on physician alignment and affiliation strategies, and we're doing charge master review and revenue cycle assessment for a few of our hospitals. We are continuing to focus on financial performance improvement to put our hospitals in a place where they can most effectively move into a value-based system. And while we've begun seeing some improvements in their financial performance, they are still struggling financially. And given all the changes that are happening very quickly, I think it's possibly more important than ever to keep up these efforts in terms of helping them to move forward in these efforts. So real quickly, I'm just going to show you, we just had a quarterly meeting of our network, and we are beginning to really see some changes in some of our financial metrics. So on this slide, there are 4 metrics that are shown: percent operating margin, percent total margin, bad debt and charity care as a percent of gross charges, and personnel expense as a percent of operating revenue. And this compares the most recent data from quarter 1 in 2016 to 2014. You can see the changes over the years. And we are really pleased to show these numbers finally, because we're, as I said, beginning to see real market improvements, and we're hoping that that quarter 2 for 2016 will give us even better numbers. Again, here's 3 more of the metrics that are improving: gross days revenue and gross accounts receivable, days of operating expense, and average age of plant. Again, just working with our hospitals to improve these numbers every quarter. So I think today you asked me to discuss this improvement, but maybe also to discuss how we were able to do this. And one thing that I didn't put on the slide that I think is the key component to all of this is communication. We have 18 critical access hospitals that are now participating in our network and are very supportive of each other. We've always had an excellent core group of about 8 to 10 hospitals, and now we're getting consistent participation from all of them. And that's really exciting, because for so long it was really like pulling teeth to get some of them to submit their data and to participate fully. So it's really nice to see, and as I put on the slide, they're very supportive of each other, even though a few of them kind of compete in their secondary markets. But they conduct site visits with each other to learn as much as they can, and they're all very open to having other hospitals come in to see what they're doing. I think that one of the reasons we're finally starting to see some more consistent improvement is that we've been doing this now, as have all of you, for quite a few years, and I think that the consistent collection and analysis of financial indicators by the hospitals is critically important. I think it forces them every quarter to look at their numbers, and I don't think that without the Flex program, I don't think that they would necessarily be doing that. So I think that consistent review has them more in tune to what's happening in their hospitals. At our network meetings, we have a discussion every quarter of some successful strategies that are coming out, and just some examples of those strategies and those discussions are emergency department throughput, revenue enhancement, maximizing staffing, departmental productivity, payer contracts, and FQHC collaboration. And it's the hospitals themselves that do those presentations, and they're always very well received, and they're always, I think, pretty happy to highlight some of their successes. Something new that we started this year is the Learning Action Network. And this is a team-based performance improvement program where the hospitals, through interviews prior to our first network meeting last fall, identified 15 priority areas that they wanted to discuss at meetings. And during the meeting, we had a consensus exercise to choose hopefully choose 3 priority areas. We actually came up with 4 because we had a tie, and nobody would break the tie, so we decided to go ahead with 4, but we combined them into one work group. So the members of the network, which are all of our hospitals, work in 3 small groups to develop assessment and action plans, and they meet via conference call and during the network quarterly meetings to discuss their progress. So on this slide here, and I have to thank Matt Mendez from Stroudwater for this slide, he put this together for us, is each of our networks. So you have 340B and swing bed, and I won't read through all the purpose and the deliverables, but you can look at that.
on your own. We have affiliation strategies and we have physician alignment. And our hope is that each of these groups will produce a deliverable and something in writing that we can then have on the shelf to be able to share with all of you, to share with the federal office, and to really have some good strategies developed for what they're doing and what they think they need to do to move forward in these areas. And I really think that this Learning Action Network, particularly around affiliation strategies and physician alignment, is what's really beginning to move our program from simply reviewing and discussing financial indicators into beginning to address value in population health. And then the last component of our program is pretty simple. It's just charge master reviews and revenue cycle assessments. And we chose 3 hospitals based on a review of cash on hand, bad debt and charity care, gross revenue and accounts receivable, and net days revenue and accounts receivable. Basically, the 3 hospitals that had that were not performing well in those 4 areas were chosen to have charge master reviews or revenue cycle assessments done. 2 of them are doing charge master reviews, and 1 is doing a revenue cycle assessment. Those will be completed this June, and we'll choose 3 more hospitals to work with during the next grant year based on the financial indicators. So that's all I have. This is my contact information if you'd like to get in touch with me apart from the webinar. And again, I thank you all for your attention and interest.
Yeah, Karen, thanks so much. That's really terrific work. The other thing I think we were impressed by was the measurement, the tracking of the improvement. Again, I do encourage you to call or write to Karen because we're seeing some real growth here in terms of our flex programs and the area of finance, and let's share as much as possible. Our last speaker in this section is Lance Keilers, and Lance we wanted to get a perspective kind of from a hospital administrator point of view. Lance is currently not running a hospital, but he has broad background in that area, and he was also one of our participants in the Financial Summit meeting. So Lance, I'm going to turn it over to you, and we're running a little bit behind. We may go over a few minutes, but if you could keep it to 5 minutes or 10 at the most, it'd be appreciated.
No, absolutely, Terry. Can you hear me okay?
Thanks. We can, yes. Thanks, Lance.
Perfect. Well, thank you, and I'll be brief. For those of you all on the call that do not know me, I ran a critical access hospital down in Texas for about 14 years, and during that period of time, I served on the Texas Organization of Rural and Community Hospitals Board, the Texas Hospital Association Board, and then in 2012 I was president for the National Rural Health Association. I currently do consulting, and I work with Terry and his group on different projects, and we work with hospitals all over the United States, but our focus is on small rural and critical access hospitals. And I give you that background to say that I'm a recovering hospital administrator first and foremost. And I want to thank Terry and TASC and the federal office for a couple of things. One of them is the Financial Summit that came out years ago in 2012 came up with some critical access hospital financial indicators that, in my opinion, a lot of hospitals are still not adhering to or addressing. And I think Karen eloquently brought that up in her presentation, that's one of the key reasons that those hospitals are turning around. I would encourage those who have not seen that document to pull it back out because it is by no means outdated. And I think it even ties back into what Dr. McKinney was talking about earlier with our financial performance. But I really feel that this second round that we recently put together with the consultants and the staff and the hospitals, the Financial Summit that we just did is the future of rural health care, and that is transitioning our hospitals from volume to value. And I want you to understand that the CEOs that are out there, a lot of them are frustrated. They don't know what to do. There's still a lot of CEOs out there that think the government is going to come up with this billion-dollar bailout plan for them so everything will be fine. We're seeing a lot of high turnover in our C-suite, which is affecting not only our hospitals, but it's also affecting our medical staff. And then as Terry mentioned, we have a lot of hospital closures happening. And in my humble opinion, I think we're going to see a lot more before it's all said and done. Being from Texas, I just wanted to report a little bit. Down in Texas, I know that Torch and the State Office of Rural Health in Texas is really working to coordinate the critical access hospitals and bring together that collegiality of teamwork. There are a lot of hospitals down in Texas, and they have a lot of miles in between them, but they understand that collaboration is going to be a success. They are focusing on outcomes in telemedicine and on regionalization as much as possible. I do think there's a lot of challenges that are facing our rural hospitals. I think the fee-for-service to the value-based revenue payment structure is still an alien concept to a lot of folks. I think that a lot of our rural hospitals are dealing with staffing issues, not only on the hospital side, but also on the physician side. And I do think that our hospitals are struggling with a lack of qualified staff. And I say that respectfully, but I say it from the standpoint that traditionally in a fee-for-service world, we know what to do and we do it well. But as we go into value-based reimbursement, the rules are completely different. We have high deductibles. The EMR incentive funds are going away for the hospitals. Our reimbursement models are changing. We have changes in legislative support for rural, and in a lot of ways, we don't have the advocacy in Washington, D.C. that we did even 5 or 10 years ago. So our CEOs and our rural hospital infrastructure is under a lot of stress and frustration, and that doesn't even take into account the local politics that a lot of these organizations are dealing with. Now, a lot of hospitals are very proactive. A lot of them have the resources where they can be proactive, and that's good. A lot of them don't, though, and that's really the ones that will need the help specifically from the state offices of rural health. The future of our rural health care delivery system, as I see it going forward, is really going to be based on outpatient services. We do a lot of lean training with hospitals, and lean hospital mentalities need to come into play with our rural organizations. We have to get better about outcome measurements and collaboration, and it was nice to see Karen talking about the hospitals in New York collaborating together without this sense of a tertiary battle. Our coordinated care mentality really has to step up. We have to start talking about our primary care medical home models. We have to start talking about population health and really engaging healthcare delivery outside the walls of the 4 walls of our rural hospitals. And as Terry mentioned in his presentation, the triple aim with the improved outcomes, the better patient care, and the lower cost will need to be the focus. I think Flex's role and the state office role going forward will continue in a lot of ways as it has, but your role of supporting, encouraging, and engaging our rural hospitals, especially those that are struggling, will be more important than ever. Hopefully the funding for Flex is going to continue to focus on outcomes and on coordination of care and on continuums of care, because whether you're an urban hospital or a rural hospital, the track record is there that that's where we're going to need to be. Now, as Dr. McKinney said, are ACOs going to be the model of the future? I don't know. But I do know that historically our small rural hospitals have focused on inpatient and volume, and we have to help hold their hand and lead them into a new era of delivering high-quality, efficient health care in our rural communities. Because if we have success, in my opinion, success is going to be directly correlated to great quality of care, efficient, lean organizations, and that will be the result, and the result will be phenomenal outcomes for our patients. Our folks that live in rural America deserve access to care locally. those models and those ideas of what that delivery system will look like may change and probably will change. But we need to continue to be advocates for the folks that live in rural America and make sure that that system that is out there is a quality system that we can all be proud of. So, Terry, I'm going to kick it back to you. I hope that I hit a few high points and I didn't go over too much.
No, thanks so much, Lance. And it's so important to have the rural hospital leaders' perspective, and thanks for articulating that. Our last speaker of the day is Sharita Thomas from the University of North Carolina, who's going to do the new campus demo, so that you folks will get a little better idea of exactly what this is and what type of resource it is. So with that, Sharita, are you here?
Yes, can you all hear me fine?
We can. Thank you for being here.
Okay, thank you for having me. So I'm going to go ahead and do a quick run through of the Critical Access Hospital Measurement and Performance Assessment System, otherwise known as COMPASS. This was designed to be an innovative tool for CAH executives, state flex coordinators, and other federal staff. It would be allowing for easy to create on-demand customized data query graphs so that these users can explore the financial performance of critical access hospitals. So I'm going to do a quick demo of this tool, and we hope that it gives users the enhanced ability to make relevant performance comparisons, also to effectively allocate funding, but more importantly, we hope that it opens doors for collaboration between peers. So when you log into the COMPASS system, you're just greeted with a welcoming page. To give you some information here, this is a part of the Flex monitoring team, and you can contact here for more help. So we would click to get started, and just to show you here some of the layouts that we have, you're able to compare data using a bar graph so that you can compare at one point in time. You can also use a line graph so that you can compare data over time. We're just going to go in here and look at some of the indicators we have. So some of our common ones that you all should be familiar with are the financial indicators. So we have them broken down here into familiar buckets so you can kind of navigate how you want to compare data. We have also added in some quality indicators here with HCAHPS data. In the next few days, we're also going to be looking at adding additional quality data into the system and reviewing it. And if things look well, we hope to have more quality data released in the next few weeks. We also have some community or market characteristic data here that you can look at, which we thought would be a nice touch to kind of compare certain demographic issues going on in your counties, especially if you're talking about population health. So let's just go back up here. We're going to run through and look at one of these hospitals here. And let's look at some operating margins. So I'm logged in here as the hospital. A lot of you on this call might be state or federal users. Your views will look a little bit different here. But when you're logged in as a hospital, you can see what kind of peer group you're in, some of your characteristics, and you can also change it by years. We're using a hospital here that had recently closed, so this is the most recent data. And what we're going to do, we want to compare. We're going to just make a custom group here and look at other hospitals in its own region. So you're able to compare by peer group. If you click that, it's just going to identify other hospitals that are similar based on these metrics here. You can also just look at those in the state. This hospital happens to be in Kentucky. We want to make a custom comparison, and we're going to look at other hospitals that are in the South that are operating a rural health clinic. And so we enter in the components that we want to see, and we can draw a graph, and it loads, and it's going to show us how our hospital here in the blue compares to other hospitals in the region, and also how it compares to the cost financial indicator benchmark here. Another important thing to note that we have some features here that indicator definition. If you're not familiar with some of these variables, you can click on that. It's going to give you some information. It's also going to tell you where we're getting the data. Another tool that we have here is you can save the data as a CSV file. So what you can do, you can make whatever kind of comparisons you want, and you can click that, and it will export the data into a file that you can compile into Excel. We might want to look at some other indicators. So we can go back here to the set indicator, and let's see how their days in accounts receivable is doing. We want to keep the South region the same, and it will load this data here. And so we can see now how the days in accounts receivable compares to those other ones in the state. So we did mention that we did have other types of graphs. So if you want to kind of go further into detail to see what's happening with this hospital, we can change the graph type here and select a bar graph. And let's again look and see their days in accounts receivable. So we want to kind of compare. We'll pick South region again, and we can load. And so this view here, again, we're logged in as a hospital, so our data is going to be highlighted here. Now, this is every other hospital that has data in the system, even the ones that are missing over here in the South region. So you can compare how the days in accounts receivable or any other indicator that you've chosen measures up to the group that you've selected. And you can see here that they have very low days in accounts receivable compared to other hospitals. These here are missing data, and this here is the benchmark number. So if you kind of want to think about what's going on, it's either a very effective revenue